Welcome to this first video module on the chapter of communicable disease. The first disease we can take up is smallpox and chickenpox. Let us first talk about smallpox, which we are very proud to say that has been globally eradicated. I think everybody knows about it, right? So talking about smallpox beta, smallpox virus, it's a variola virus. It is a poxviridae double-stranded DNA virus. If you talk about a little bit about features, clinical features, nothing very serious into it, you should know smallpox, which was a disease in old times. It was associated with high-grade fever, with a maculopapular rash, which was rushing over to form the vesicles and then to pustules. So the characteristic features was all the rash was at the same stage at the same time. So there is no pleomorphism. All the rash would either be in the vesicle stage or in the pustular stage. That is what is the characteristic about smallpox. The smallpox rash would typically start maculopapular rash from the face, and then it will extend downwards with more in the extremities. It will be more in the extremities, in the limbs, upper limbs and the lower limbs. The diagnosis was by laboratory confirmation. So actually this rash is what differentiates a smallpox rash from the measles or the chickenpox rash, which is more, again, like in measles, it will start from the face, but it will extend to the abdomen also. So in smallpox, it was more concentrated in the face and palms and soles in the extremities. So now, in fact, this is the only slide, this is the only point for your MCQ exams about the historical relevance. So there's only one MCQ in smallpox you need to study. The first point you need to do is that when was the smallpox vaccine discovered? The smallpox vaccine was discovered in 1796. The smallpox vaccine was discovered in which year? In 1796. Who discovered? Not somebody else except
Edward Jenner.
The great
Edward Jenner,
also called as the founder of vaccination or the father of immunology, because that is what gave us the understanding about immunology. Next in line is 1967. The WHO, they started smallpox vaccine on a global scale. So that is what is the force of our department. That is what is the force of public health or community medicine, that in 1967 you start a vaccine on a larger, bigger scale. And there you go. In just how many years? 1975 was the last case of smallpox. Last smallpox case in India was on 24th May 1975. And subsequently on 5th of July 1975, India was declared as smallpox free country. And then by an international commission, 1977, April 1977, India was declared as smallpox eradicated country. Eradication in India was declared in April 1977, and subsequently, I think the world knows that May 1980, the smallpox vaccination was stopped and the WHO declared a global eradication of smallpox. So global eradication of smallpox is there from since May 1980, and the Park textbook writes that still the last chapter on smallpox is yet to be written, because the smallpox virus is still there, so we don't know what's going to happen next. But all said and done, these are the MCQs you need to remember. So now let's move ahead and talk about the next disease, that is chickenpox. First MCQ, chickenpox is also, it's a viral disease, right? It's also called as the varicella virus or the varicella zoster virus. The chickenpox virus, it is a human herpes virus 3, that is the varicella zoster virus. It is a double-stranded DNA virus. If you talk about the source of chickenpox, how does a child get chickenpox? Please note that the source is another case of chickenpox. Source is the another case of chickenpox. If a person has chickenpox, are the scabs infective or not? This is such a frequently asked MCQ. Please note that the scabs are not infective. The scabs are not infective in a case of chickenpox. However, the vesicles or the fluid in the vesicles is infective. That is infective, that is the source. So source is who? It is the case of chickenpox. What is the period of communicability? Let us say that this is the onset of the rash. If this is the onset of the rash, beta, 1 to 2 days before the rash and till 4 to 5 days after the onset of the rash. 4 to 5 days after onset, not the end of the rash, after onset of rash is the communicable period. So through the rash, people or the children might be communicable. That is what is important to understand, and in fact they might be communicable even before that. What is the secondary attack rate? In your park textbook, sometimes books will try to confuse us. There is a difference. I don't know, that's a bad thing to say, but there is a difference between a second attack rate and a secondary attack rate. I know it's so bad sometimes that why do you make the things more complicated? So please note that there is a second attack rate. What do you mean by second attack rate? That means in a person, can the virus come back again? So that is separate. What is secondary attack rate? It is the number of subsequent cases or the number of secondary cases which arise from a primary case. So that is secondary attack rate. So I'm basically talking about secondary attack rate. The secondary attack rate for chickenpox is 85 to 90%. If you get the single best answer, please note it is 90%. It has a very high secondary attack rate. Next in line is what is the host factors. So we are talking about the epidemiological determinants. We talked about the agent factors. Now is what are the host factors, beta? What is the peak age group? The peak age group is usually in early school going children. It is almost always less than 10 years is the peak age. So almost always less than 10 years. It could be as early as 5 to 6 years, or it could be around 10 years. Regarding immunity, that is kind of important thing to understand, that if a child gets chickenpox disease, can the child get again chickenpox disease? Answer is no. So there is a lifelong immunity, but please note, you already must be knowing it, that in a case of chickenpox, the virus, this person, the human herpes virus number 3, it loves to stay in the nerve cells. So it loves to stay in the nerve cells, and there may be reactivation. So there is a chance of latent infection. There is a lifelong immunity with chickenpox. So chickenpox will not develop. But if the infection was latent in the body, this may land up into a zoster infection. It may land up into a zoster infection, that is a reactivation or a latent infection which was activated. MCQ about pregnancy. So in case a female is pregnant, now there could be some serious problem, not to the mother but to the child. Please note that if the mother gets varicella infection in the first 20 weeks of pregnancy, then there is a high chance of congenital varicella syndrome. There is a high chance of congenital varicella syndrome. How much high chance? It is 0.4 to up till 2%. Up till 2% of children may unfortunately develop a congenital varicella syndrome in pregnant females. So when is beta? Just remember, in the early parts of pregnancy, it is the rubella infection which is dangerous, and also the chickenpox infection which is dangerous in the early parts of pregnancy. Coming over to the next point, that is the environmental factors. Talking about environmental factors, chickenpox can occur at any time, but it does have a seasonal trend. What is the seasonal trend? From Jan to April. What do you mean by Jan to April? It means winter months and spring months. So it is kind of more in some seasons. About the environmental factors, one more MCQ, that this chickenpox virus, it's a very sturdy virus. It can live outside your body. But for how much time? Please note, it may survive for 24 to 48 hours outside the body. May survive for 24 to 48 hours outside the body. And this chickenpox virus is a very fragile virus. It can be easily destroyed. It can be easily destroyed by chemicals. Which chemicals? By some solvents or any detergent. So any detergent or any solvent can easily kill this chickenpox virus. Next in line is what is the mode of transmission of chickenpox, or what is the incubation period? The incubation period has been asked hundreds and thousands of times. It's a frequently asked question. The incubation could be as low as 10 days to as high as 21 days. What you can remember for your exam beta is that the average incubation period is 14 to 16 days. If you get a single best answer, you can mark 15 days as the average incubation period. What is the mode of transmission? The mode of transmission for chickenpox, it is a droplet mode of transmission. For chickenpox, it is a droplet mode of transmission. There could also be the mother. You remember we just now talked about the host factors, that the mother can also give the infection to the child. So the transplacental mode may also be there. Transplacental mode. Alongside, the infection may also have airborne mode. Please note, if you just look at the chapter where we discussed about the concepts of community health, where we talked about the modes of transmission, infectious disease epidemiology chapter, we talked about modes of transmission. There is a direct mode, indirect mode. The droplet form and the transplacental, they form the direct mode of transmission. Airborne are the indirect mode of transmission. This can be another MCQ: which infections will have airborne mode of transmission? Please note that the airborne mode of transmission can happen in IMCTC. Just remember IMCTC. I stands for influenza, M stands for measles, C stands for chickenpox, T stands for tuberculosis, and C stands for your favorite answer, COVID-19. Whatever happens today, answer is COVID-19. You see COVID-19 in the option, you mark COVID-19. So that's how bad COVID-19 is. So just remember, please note that the chickenpox may have a direct mode of transmission and indirect mode of transmission. Coming over to the clinical features of chickenpox, they can be broadly classified into pre-eruptive phase or the prodromal phase. And then you have the eruptive phase in chickenpox. In the prodromal phase, nothing very special. There could be fever with coryza, runny nose, or there could be body aches for the child. And then in the eruptive phase, now the eruptions will start happening. The eruptions will characteristically start in trunk area. And from the trunk, they will spread up and down. They will spread to whole body. They will spread to whole body, including the mucosa. But please note, it does not involve the palms and soles. The palms and soles are not involved. Another characteristic feature about this rash, about the chickenpox rash, you can write it down, is that this rash will show pleomorphism. What is pleomorphism? Pleomorphism means that at different stages of the rash, the macular stage, the pustular stage, the vesicular stage, and the scab phase, they will be available. You can see that rash at a single point in the child. So different rashes will be at different levels. So that is what is pleomorphism. Another feature about this rash is that the scabbing will start in around 4 to 5 days. And please note, I've already told you scabs are not infective. So who is infective in a case of chickenpox? It is the vesical fluid. Of course, the fluid, if it is directly in contact with the other person, that may cause infection spread, but technically speaking, majority of times chickenpox has a droplet form and it has airborne mode of transmission. Coming over to complications in chickenpox, the complications are very rare. It is less than 1% of the children will land up with complications. The complications could range from hemorrhage to pneumonias to some brain inflammations, encephalitis, or acute encephalopathy, that is brain encephalitis, that is brain inflammation with edema and with fatty degeneration of the viscera, especially talking about the liver. So what is this called as? This is called as the Ray syndrome. This is called as the Ray syndrome. It is all our rare complications. Almost all are rare complication. Only one complication may be asked to you in your exam, beta, that pneumonias. If a child has pneumonia, this pneumonia could land up into a severe pneumonia. So pneumonias could land up into severe pneumonias, and this may be dangerous for the child. Otherwise, complications are pretty less in case of pregnancy. But complications, specifically talking about complications in pregnant females, in pregnant females, this may cause a congenital varicella syndrome. We already discussed this. This congenital varicella syndrome has roughly 2% chances of being happening in a child who is born to a female who has already got varicella within first 20 weeks of her pregnancy. So now this child may be developing cutaneous scars, limb atrophy, cortical atrophy, microophthalmia, and microcephaly. These are two characteristic features of congenital varicella syndrome. Along with that, there could be chorioretinitis or deafness. How do we diagnose the varicella? Can be diagnosed using a varicella zoster virus DNA PCR test. There is no ELISA. Otherwise, mostly like in most of the clinical scenarios, the diagnosis is purely clinical. Next one is prevention and control. Beta, if you talk about prevention and control, there are basically two modalities. Either we can give a vaccine to the child, that is the live vaccine that we already have, that is active immunity, or we can also give the passive immunity. Passive immunity to the child. What do you mean by passive immunity? That means in passive immunization, we can give the varicella zoster immunoglobulin. So we are going to give the varicella zoster immune globulin. There is a special indication for giving this varicella zoster immune globulin. The indications are that it is actually given in those cases where the live vaccine is contraindicated. So the indication is, first is in case the pregnant female is there with a known exposure to varicella, pregnant female is there. A mother is there, her child is already there, and she is again pregnant, and the child unfortunately got chickenpox. So now the female is at exposure because mother is there, the child is there. Second, this is also given in cases of severe immunocompromised state. What is a severe immunocompromised case? In patients or children who are HIV positive and symptomatic. If a child is HIV positive and symptomatic for HIV, or in cases of long-term steroid therapy, long-term steroid therapy, again, that is a severe immunocompromised state. Also, the prevention using passive immunization is given to children, infants who are born to varicella or chickenpox infected mothers. So, and especially if the child is premature or if the child has low birth weight. In those high risk cases where you cannot actually give a active immunity, you want to stop the infection immediately, you give a varicella zoster immunoglobulin. The varicella zoster immunoglobulin, beta, just remember it should be given within MCQ 72 hours of exposure. Within 72 hours of exposure. Okay, it is given at the dose of 12.5 units per kilogram, given maximum not more than 625 units to a child, and this should be given within 72 hours. And in case of the exposure is prolonged, or in case the varicella is still there in the house or something like this, in case of prolonged exposures, the varicella zoster may be, it's not mandate, it may be repeated after 3 weeks. That brings to your understanding that the effect of the zoster immunoglobulin is only for 2 to 3 weeks. It's not very, very effective, but yes, it is expensive and it is given only in certain indications. And please note, with the varicella zoster virus, never combine with the varicella vaccine. Never combine with the varicella vaccine. Next one is active immunization, beta. Active immunization is your favorite answer. That is your live attenuated vaccine. MCQs on the live attenuated varicella vaccine. What is the strain of the vaccine? The strain of the vaccine is OKA strain. OKA strain. It is given at the dose of 0.5 ml subcutaneous injections. It is usually given at the dose of, in the age of 12 to 18 months of age. It is given as 2 doses. 2 doses, 12 to 18 months of age. And then we can give a booster dose roughly around 4 to 6 years of age. So that is the schedule. It is given in 2 primary plus 1 booster. Please note, in Government of India, we are not giving this vaccine. It is only given in the private clinics by pediatricians and recommended by the Indian Academy of Pediatrics. So, but it's not given under our Sarkari under our government program, National Immunization Schedule. So now a point for you to understand is that what is the recommendation? Recommendation of this vaccine is it should be given 12 to 18 months of age. This vaccine should be given, it is recommended to all children 12 years of age. So till 12 years, all children should be taking. Ideal age is 12 to 18 months, and then you give a booster dose. So 2 points done. Third point is, do you also know that this varicella vaccine it is recommended to be taken by adults also. That is age more than 13 years. So it can be taken age more than 13 years in case there is a varicella exposure. In case of varicella exposure, I'm just going to talk slightly in detail about it, but for now just understand what is the recommended age beta for varicella. It is 12 to 18 months. It can be given to age less than 12 years, and it should be given to age more than 13 years in case there is a varicella exposure, in case there is a risk of varicella exposure. Now the problem starts. The problem starts is that till 12 years of age, under 12 years of age, the vaccine is recommended in 2 primary doses, plus you give booster at later on. But the gap between that is what the MCQ is. The gap, understand the word gap between 2 primary doses, it should be 1 month to 3 months, not less than 1 month. It should always be more than 1 month, and it should be less than 3 months. So the gap should be between 1 to 3 months. If you get single based answer, please note that the gap should at least be 1 month. More can happen, but at least be 1 month. But only for age less than 12 years. Are we okay with this? In case we are giving to adults, in case of adults, now the gap should be 4 to 8 weeks. The gap should be 4 to 8 weeks. That means from 1 to 2 months. So again, it should be minimum 1 month, but recommendation is between 4 to 6 weeks, 8 weeks. We can have in cases of adults. That is what the only MCQ is. The third point is about the post-exposure prophylaxis. What is in case of post-exposure prophylaxis? Just now we already talked on that about the adult vaccination. That's what I was referring to. In post-exposure prophylaxis, in case of known exposure to varicella virus. In case of known exposure to varicella virus, we can give the varicella live vaccine. You can give the OCA vaccine. This should be given within 5 days. Within 5 days of exposure. It should be given within 5 days of exposure. Of course, contraindication of the viral vaccine is severe immunocompromised state, it is pregnancy, and it is anaphylaxis. We already did all this, right? So the contraindication to the vaccine would be severe anaphylaxis, severe immune compromised state, HIV patient, transplant patient, and in case of pregnancy, it is not indicated. Otherwise, we can give till 5 days of age. Otherwise, in case the vaccine is contraindicated, go with the varicella zoster immune globulin. Right? So with that, thank you so much for watching this module. See you in the next chapter.